Well, welcome everyone. I'm really excited for this episode of HCP Rounds because we're joined by Frederik Verbrugge from Brussels. If you don't know Frederik, he is a cardiologist, incredible researcher, specifically researching multimodal diuresis and decongestion, and then also very active on social media as an incredible educator. And recently, actually, we just hung out with Frederik in Montreal for hospitalist resuscitationist, had a great time there. So just really nice to yeah, really nice to see you again and glad to have you on here.
Pleasure to be here. Like I'm always impressed by the people from Canada and glad to join forces.
Oh, looking forward to it. Sweet. Well, we're going to be talking about how to become a diuretic Jedi, although I realize that I actually put a Sith Lord. ChatGPT got a little bit confused when it was generating the cover image for this. We'll let that slide and kind of hop into it. But before we get into kind of the nitty-gritty content, we do have to thank our sponsors for HCP Rounds. And the first one I want to thank is Flowsonics. And they've been our sponsor for HCP Rounds really since the beginning. And if you don't know, they produce a flow patch, which is a kind of wireless wearable carotid and jugular Doppler patch. And really recently, I don't know if it's approved yet, but if it's not currently approved shortly, their jugular vein Doppler is actually undergoing FDA approval, which will allow them to essentially give a non-invasive VEXIS score, highly relevant when we start talking about decongestion. It's really exciting to see what they're doing, and they certainly kind of match the mission that we have at HCP Rounds about getting these hemodynamic assessments out to as many people as possible. So thanks again to the team at Flowsonics and creators of Flow Patch for helping that out. Um, the next thing is kind of a personal thank you that I wanted to make to the HCP Rounds community. For the past better part of a year, I've been working on a platform, Resub, which is essentially helping automate different parts of the research process, be that formatting manuscripts, writing manuscripts, and improving kind of language, cover letters, reporting guideline checklists. And to thank you to the many of you on the call right now. I can see over a dozen people who are actively using this, who are hopping on calls with me to provide feedback, to improve the user experience, to make this just better and better. And so I'm just tremendously grateful for the support that everyone has provided for Resub. And you can definitely check it out at resub.app. And if you ever want to hop on a call and you have a great idea for how we can build something that makes your life easier as a researcher, I would love to hear it. So thank you guys. And then I'll hand it over to Eduardo because he's launched something super cool that I'm really excited to hear about.
Yeah, thank you, Ross, for the space. And then I'm taking advantage that most of our audience was very keen on learning about hemodynamics and venous congestion. And I'm very proud to say that we now have a complete curriculum on venous congestion. It's a really nice course that we put together in pocusfocus.com. This includes lessons, cases. Here's an example how the web page looks. So this is you can access the introduction, acquisition, interpretation. Here's an example of case one. So you see a vignette, you're ready to start, and then after you click the ready to start, you'll get a nice case presentation with images and questions, and then you'll get a video feedback of what you should do with this information. I think it's a really complete course. And then I invite everyone that's interested to join us here at pocusfocus.com, which is in the next slide.
Yeah, and I just want to say, Eduardo, that you and I, as part of Andromeda Vexus, which we finished recruiting over 400 patients worldwide across 20 centers. You and I have reviewed quite literally hundreds of cases together every week where we've gone through in depth into waveforms. And I know that your idea was how can we kind of take some of those conversations and learnings that we have from literally discussing this hours every week and share that with everyone out there. And so I'm really excited to go through it. You know what, I've learned so much from you over the past few years with that study. So I'm glad that you're able to share that to even more people.
Yeah,
All
I'm
right.
actually going to take that to kickstart our conversation. Just to say that actually Frederik, we met through social media, and one of the most important reasons that we clicked is that he was one of the first cardiologists who got interested in venous congestion and venous Doppler assessment. We were very big in the critical care nephrology circles, but then cardiology wasn't really paying attention. And then when Frederik started paying attention, I think it just blew up. And this is part of how we started talking to each other. And I'm very glad to now call him my friend. And it's an honor to have you here, Frederik.
Vice versa. I think that when I came for the first time and back then on Twitter, now X, I learned a lot from you guys And I was surprised how much of the knowledge was actually completely known in the cardiology field, where we were looking at the caval vein always, but never at the portal vein. And I think this has tremendously changed over the last years, and there has been a big pickup in the cardiology world as well. And I'm really thankful for you to sharing that knowledge, and this site and lessons. They seem wonderful. Highly recommended.
Incredible. Well, let's kick it off here a little bit. So, what's wrong, or maybe not what's wrong, but why do we need to talk about multimodal diuresis here? I have an overloaded patient. I'm going to start them on Lasix. Lasix works. They pee out water, they pee out some sodium. They often just get better. So why do we need to make this more complicated than what it actually is? So that maybe I guess that'll be my role today, is maybe to play devil's advocate a little bit and maybe challenge you guys on why do we need a change in paradigm here?
I think that one of the key things is that we manage to get fluid out quite easily with Lasix. I think that we're going to come back on this later on and see that what we pee out is actually important as well, because it's not only water, there's a lot of electrolytes in there, and we don't only want to correct fluid base, we also want to achieve homeostasis. And then, yeah, the first thing, and maybe the most important thing is we should get the job done of getting to euvolemia. And very often, as we will show you some data, this is not the case. We get some response, but we are very often not able to decongest the patient completely. Do you agree, Eduardo?
Yeah. I think this is a very frequent thing that we just reflexively get diuretics, look at the urine balance, and then let's say, well, the patient's been in negative urine balance for a couple of days now. I think we're good. We're good to send him home. And then there's really no reassessment. And then many things could have gone wrong. Maybe we under quantify the fluid intake of the patient. Maybe we under quantify the salt intake of the patient. Maybe we weren't paying attention to sodium balance. And then, of course, the patient might end up going on still congested. And of course, it's very likely to come back to the hospital.
And Frederick,
And euvolemia
you
is
have
so
command.
difficult.
Yeah, 100%. I was just going to say you have 10 commandments here of diuresis, or maybe even more than 10. What are the commandments that we should be thinking about? So what do you mean when you say get the job done?
So get the job done means just like get rid of all of decongestion. So really get to euvolemia. And as actually assessing euvolemia, it's much harder than assessing volume overload. We can easily see volume overload. It's not so easy to see when we are at euvolemia. We will come back later on this, I guess. I think one key thing is that we shouldn't be distracted too much by serum creatinine levels. Again, we will dive into this point specifically afterwards, but this can be a distraction sometimes, letting us to underdiurese. Then the next one, it's about the next couple are about how we can really optimize our loop diuretic treatment. And we will make some arguments to prefer, if the patient is in hospital and fluid overload, to prefer intravenous administration. Then also getting the right dose, and not only the right dose, also the right frequency. And those two things are different, like 2 times 40 milligrams of furosemide or Lasix. It's not the same as 1 times 80. We will come back on this as well. I have a preference of bolus over drips. I think this is a little bit controversial. I will tell you my arguments for this later on. And then I think it is important to realize that volume and pressure, they are actually 2 different things. And there is absolutely the possibility of having normal cardiac filling pressures and still clear fluid overload. Also, the reverse is possible, where we have euvolemia and elevated filling pressures. If I get a rupture of a chordae of my mitral valve, I can easily get into lung edema, even though I'm now perfectly euvolemic. So we will then make a strong argument that we should use all the diuretics we have, not always. We should individualize them, but using combination diuretic therapy is really helpful to maintain homeostasis. And this means that there is no one fits all sequential approach that is the same for every patient. Patients are different and need different medications. There's not a good or a bad diuretic. There's only a good or a bad indication. I already hinted that it's not only important to get urine output, it's also important what is in urine output. And I will make a strong pledge that actually urine sodium and natriuresis is a very important target. And decongesting is actually getting natriuresis, while only getting free water excretion is called dehydration, and that's a form of torture. Urine sodium assessment might be very helpful to monitor this response and actually see the difference. So these are my 10 points.
I think those points are a great way to start on this subject of diuresing and natriuresing. And I want to touch just on two of them. The first is, and that's a sacred, and the whole point of this webinar is to really get people to think about natriuresis and not just diuresis. And I don't know if you agree, Frederik, but the way I usually convince people of focusing on natriuresis is by showing them the results of the Vaptans trials, where they give Vaptans to patients with congestive heart failure, and they will achieve great diuresis, and the patient will lose weight. And that actually was the surrogate outcome, so that the patient is losing weight. So that must mean the patient will do better. But when you actually look at congestion markers, BNP, breathing and hypoxemia and lung edema, we actually get no benefit from inhibiting water reabsorption at the distal nephron. So I think that's a really clear example that just achieving diuretics might not get the job done.
Yeah. So,
Completely
Frederik,
agree.
I was just going to ask, so where are we at right now in 2025 or 2024? How good are we at diuresing patients?
Yeah, so you can see at least we cardiologists, we are not really doing a good job. So this is on the left-hand side, you see a big European registry. So this is really reflecting European practice. It's kind of a snapshot, 2019, not so long ago. And what you can see is that patients with acute heart failure, they invariably come in wet, but 1/3 of them actually goes home wet. And this is not a European thing. On the right side, you see the North American part, and you can see again, like 1/3 of the patient actually going out of the hospital with a weight that is higher than when they came into the hospital. So there's definitely a lot of things we can do to improve.
Okay, that makes sense. Now, maybe I'll put this one to you then, Eduardo. So we're diuresing a patient. They come in clearly acute decompensated heart failure. You start giving them Lasix, maybe you add in some metolazone and some of the other stuff that we talk about, some acetazolamide. And then you notice that on day 2 and day 3, the creatinine starts going up. And it might not be you who thinks this, but somebody, I promise you, will ask you, could the patient be intravascularly dry at this point? Are we going to diurese them into renal failure? How do you conceptualize creatinine during the acute diuresis of patients?
This is a great question. I think that's an old one. And when I was a medical student, creatinine was the most important problem when diuresing a patient. Everybody was running into circles trying to stop diuretics because of a rising creatinine, and then of course the patient will get more congested, and then you'll restart the diuretics. I think, and I'll make a bold statement, which I'm not sure it applies, but it'll get you thinking. Patients with heart failure would fare much better if we just banned serum creatinine test from the laboratory. So if we were actually just monitoring symptoms, diuresis and natriuresis, but actually couldn't get the actual lab test of creatinine, I think the patients would have a better outcome, because we get scared of an increasing creatinine that we now know from several pieces of evidence that does not represent tubular injury. In some cases, it's hemoconcentration, but there's also been very well hemodynamic studies where this is not, it might not actually just be hemoconcentration. This is actually hemodynamic process going in the glomerulus, that it might be a true reduction, a small reduction in cardiac output, but also intraglomerular hemodynamic changes that will increase creatinine, while this will not cause, in most of the cases, tubular injury. And it's just a transient hemodynamic rise in creatinine, which even if it rises, this is associated with you doing the right thing, which is decongesting the patient. And then, of course, the patients that have an increase in creatinine after diuretics, they have a better outcome. And this is just a reflection that you did the right thing. You gave diuretics in spite of a rising creatinine, which is not acute kidney injury. Would you agree, Frederik?
So I always think if you look at GFR, this is actually a multiplication by the number of working viable nephrons and the single nephron GFR. Everything you're going to do in acute heart failure is going to change very rapidly your single nephron GFR, like transient hypovolemia, hypotension, like all those things, changing volume balance is going to get like a lot of variability in your single nephron GFR, and therefore there are also going to be variations in your total GFR. But what you're really concerned about is about that number of viable nephrons. And basically, the best thing that you can do to have and keep viable nephrons is to optimize hemodynamics, which means ensure that there is enough forward flow and also make sure that like there is no venous congestion, because this also impairs the renal blood flow and this leads to damage over time. And serum creatinine is just a bad test for overall GFR. So there are like issues with the test itself. But even if it was the perfect test, like total GFR, it is not a target. The target is the number of nephrons, and we cannot assess this in acute heart failure, which is why I totally agree with Eduardo. I don't think that serum creatinine is a very useful test in acute heart failure. I think if it rises and you pee well, like I'm never concerned, whatever the serum creatinine goes to. If the patient stops peeing, like no matter what the creatinine does, you're in trouble. Like, or you have misjudged. So urine output is much more important.
Absolutely. Yeah. Thanks for that. Well, let's move on then. So when we have patients as an outpatient, for the most part, we're using oral diuretics. When patients come into hospital as an inpatient, most of the time we're using IV diuretics. Some ICUs use continuous diuretics as opposed to bolus diuretics. We're going to start talking about the pros, cons, and how we conceptualize this. So, Frederik, what's your approach? When are you using oral? When are you using IV? What's your dosing strategy? And I think we have a few slides to go over this.
I think the key thing you should know about loop diuretics is that they have a threshold and also a little bit of a ceiling, although that is a little bit controversial, but they certainly have a threshold. And this threshold, this increases when your hemodynamics are worse or when your kidney function is down. So the lower your GFR is, the higher you need to dose. And this is the first problem that you encounter a lot in clinical practice. Like people see a fishy kidney function and they are afraid. So they try with lower dosing of diuretics. Totally wrong. Like the poorer your GFR is, the higher you're going to dose. Otherwise, you risk to not reach the threshold. And this is the most important reason why if you're in the hospital in a clearly fluid overloaded patient, then you should go for IV administration. You can see on the right-hand side, IV means you have a high peak, and you actually need this high peak to overcome the threshold. With oral diuretics, you have a little bit of a longer working because the absorption is more slowly, and so also it's a little bit longer in the blood, but your peak is lower and you risk being below the threshold. If you eat together with the loop diuretics, this is even more pronounced. So if you eat, you will have a longer effect, but a lower peak. And if this peak is below your threshold, you would have a suboptimal effect.
Absolutely. Well, let's move on then to talk a bit about the dosing. So you have a patient acute decompensated heart failure. What's your dose? And I'll put this to you, Eduardo, first, and then I'll put that back to you, Frederik.
Yeah, well, this is something that we're always getting into fights because the people way over underdose Lasix most of the times. When you get a patient with severe congestive heart failure, especially if there's RV dysfunction, and RV dysfunction will lead you to congestive nephropathy, or you have CKD, then of course you can't do your classic 2 times your home Lasix dose, which for most people this means just converting whatever they're taking orally to IV, since IV bioavailability is usually kind of around twice of what you get with oral dose. I tend to go like depending on on the urgency I have to decongest, I tend to go on the higher side of the allowed or socially acceptable Lasix dose. And I think this formula that Frederik's sharing with us, that H plus BUN equals your Lasix dose, is a nice way to say it. I'll just go and say, just give it 200 milligram bolus and let's see if the patient urinates. And then, of course, I'm not thinking of my first Lasix dose as an only diuretic. I might add from the get-go a second or third diuretic, depending on how much fluid I think I'm going to remove from this patient.
And wait, I just want to maybe outline that. So your initial diuretic dose, you're giving 200 milligrams, totally casual. You're just popping it in and then walking away, sort of thing. So, and I have to say that my practice has certainly evolved to be more than that. But I know that many people feel uncomfortable with higher doses of Lasix, autotoxicity. They're like, is this all a myth? And maybe I'll answer that partially. I know that back even a decade or two ago, outpatients were on 1 or 2,000 milligrams BID of oral Lasix to manage volume overload before we realized that there was other RAS blockades, for example, in heart failure. And those patients didn't really develop autotoxicity. So I guess maybe putting it to you, Eduardo, really quickly, like, do you worry about the autotoxicity? And then I'm curious about your approach, Frederick.
I personally don't, and I want to ask Frederick about that. Have you ever seen autotoxicity? I mean, the case reports of autotoxicity that come from the New England Journal of Medicine back when it was called the Boston Medical Journal, they're giving 4 grams, maybe 3 times a day of Lasix, and we're really not using those doses anymore. We know there's a ceiling after which we get no more effects, and there's really no need to go to 4 grams every 4 hours or so. And I think too, I've never seen either a case report or a personal case where we had any autotoxicity problems with your 200 bolus or 600 milligrams Q 24 hours of furosemide.
I've seen it once, I must say, in a patient that accidentally got a bolus of 450 or something. So, but I don't think you will see it with 200 or 160. So I think we should be aware that actually what guidelines recommend in cardiology is to double the home maintenance dose. So this comes from the dose trial. But if you look well at the dose trial, you will see that actually after 3 days, 85% of patients in the dose trial, they had persistent congestion. So they had 85% treatment failure with that strategy. I don't think that this makes sense, because who has determined what is the home maintenance dose? This may be like a very wise guy like Eduardo, or it might be just a totally random
Yeah.
dose that was determined by somebody. So I don't think that this really makes sense. We should be aware of pharmacology. And we know that if GFR is more poor, we should increase the dose. So what I always propose to the fellows is a very simple rule of thumb, that use 80 as your minimal dose, which corresponds to 2 milligrams of bentonite. If your GFR is below 45, go to 120, and if you're below 30, go to 160 to 200, as well. And then with just a very easy lab test, you already have determined what is going to your dose. And you will see, if you do it like that, you will never ever need to double the dose again because of insufficient response. Because if you choose your dose right from the beginning, like, there is no point of doubling the dose. If you're not going to pee on Eduardo's 200, then the chances that you're going to pee on 300 are very low. You need to consider something else there. So I would argue, go for bolus dose. One pearl for me is that one ampoule of bumetanide is 2 milligrams. That equals 4 ampoules of furosemide, at least in my country, because furosemide is 20 milligrams, which is 1/4, is half a milligram of bumetanide. So when you're prescribing, let's say 160 furosemide or 4 milligrams of bumetanide, that's exactly the same, but that's only 2 ampoules in bumetanide, and the nurse will do that without any problem. But you will get, every time you will get them on the phone if you prescribe a bolus dose, giving 8 ampoules of Lasix in one shot. So if you have bumetanide, this is more convenient for yourself.
I love it. I love it. Maybe then let's talk about the dosing. And you know, this is something that I learned, I think maybe as an IM resident, somebody told me this and it kind of blew my mind that the reason why Lasix is called Lasix is that it lasts 6 hours. And for any of you that this is a light bulb moment, I remember when I had that moment too and somebody explained it to me. So talk to me about how the Lasix dosing schedule works in your mind and why the 6 hours influences kind of how often we should be dosing it, and maybe touch on like why are you saying that boluses are better than infusions, for example?
By the way, Bumex, it's better urinary excretion. So all these names, they make sense. So no, both Bumex and Lasix, they last 6 hours, which means that the effect is worn out after 6 hours. This means that if you want to have a continuous effect over the day, then you need to repeat the bolus dose. So I will go for loop diuretic administration 1, 2, 3, or 4 times daily. And so I said previously that the dose depends on the overall kidney function. The frequency will depend on the amount of fluid overload. If there's a lot of fluid overload, we want to speed up, we want to have a continuous effect. If I want to go faster, if I want to get more fluid out, I dose more frequently. I don't increase the dose, that depends on the GFR, but I increase the frequency if there's more fluid overload, or if I want to go more rapidly. Because if you are giving only one dose, and we will come back to that in a moment, every loop diuretic will increase neurohumoral activation and will increase your body's anti-natriuretic systems. And so during that period, like every pinch of salt that they get in through their food or through anything else, medication administration, they will be very eager to keep that with them. So if you want to have a continuous effect, you need to repeat the bolus. And a very often cycle is you get somebody in acute decompensated heart failure, you get a positive response, like the first 24 hours, most of the patients, they have a positive response, and you stop too early. The patient is inadequately decongested. You switch to oral dose because you're not there yet. You overdose your oral, you get more neuronal activation, you get low blood pressure. You're not able to uptitrate your disease-modifying therapies for heart failure, and your patient will be at higher risk of coming back in with congestion. So just like with rheumatology, they attack the arthritis very heavily in the beginning, and then they get to a low maintenance dose. This is what we should do in heart failure as well. Tackle the congestion aggressively, and then get to as little maintenance dose as possible.
So I'm gonna push back on the drip thing a little bit. So I definitely subscribe to your bolus, so I'm playing a little bit fictitious pushback here. The biggest advantage I see to using a Lasix infusion is that when you order 20 milligrams an hour of a Lasix infusion, that's 480 milligrams a day. Nobody bats an eye about that. But if you order 160 IV Q8, people are going to think, "Oh my God, you're giving so much Lasix, like you're crazy." So is 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 there an advantage to a Lasix infusion beyond just tricking people into giving more Lasix than they realize? And why or why not? And maybe I'll put it to you first, Eduardo, and then pass it over to Fred.
Well, you gotta think about the kinetics also of the blood concentration of furosemide or bumetanide that you'll achieve with a drip than with a bolus. So even if you're giving the same amount of Lasix as a form of a drip or a bolus or several boluses in 24 hours, when you give it as a bolus, you make sure the blood concentration rises way above the threshold for natriuresis. When you're giving as a drip, you might not reach that threshold because the serum concentrations will be steady across the day. And so you end up running into the possibility that even if you're giving a high enough dose of Bumex or furosemide, it's not getting to the peak natriuretic effect that you'll get with boluses. And also, boluses have the advantage that you can monitor the response after the peak time of diuresis, which is 2 hours approximately. So you'll know immediately whether your decision is working. When compare that with the bolus that you usually, you prescribe with the drip, you prescribe the bumetanide infusion or the furosemide infusion, you leave the hospital, nobody knows if it's working, and you say, oh, it's only been a couple of hours, give it time, and then after 24 hours you realize you did nothing. So with bolus you learn immediately whether you're doing a good job, and I think that's a main reason I like bolus, also because of the kinetics of the rapid response and the threshold that it will because the concentration of furosemide would just shoot up, and then of course it will do its job and then come back down. You need to redose, but you're making sure you're reaching these thresholds. What do you think, friend?
So I agree. And one extra argument is what is shown here in this paper. This is actually a sub-analysis from Caress and dose. And you can see it shows you plasma renin activity. And you can see that actually whether you dose higher or lower, this doesn't have so much impact on your neurohumoral activation. But having a continuous drip certainly increase your plasma renin activity. So, and this means because loop diuretics, they have, even without any effect on volume or natriuresis. So if you show the next slide, you will see they have a direct impact on the neurohormones. And that is because the kidneys, actually, they have a spot which is called macula densa, that is actually a chloride sensor. And the way the chloride moves into the macula densa cells, it is through the sodium potassium chloride cotransporter, which is inhibited by loop diuretics. And so when you inhibit the chloride influx, the cell will depolarize and will get prostaglandins and NO production that will, in the adjacent afferent arteriole, will release renin into the circulation. So basically, the direct effect of a loop diuretic is to produce renin activation, so increase neurohumoral activation. And so by having more of a higher peak and deeper trough, you will release that neurohumoral stimulation a couple of times, and you will also have a higher chance of going over your threshold. So pure pharmacologically, it is better, I think, to go for bolus therapy. The way that I do it is when I round in the morning, I determine the number of boluses for the day, which is 1, 2, 3, or 4, until the next morning. And after the morning, I'm already assessing the response during my morning rounds, and I will determine for the next day. So I assess it one time daily, but I determine the dose and the amount of boluses for the next 24 hours, based also on what I see for a response. And that's actually very easy for the nurses. They will buy into this. Once they are accustomed to this, they will like it.
Yeah,
I
this
think
makes a ton of sense.
I want to take advantage of this point to kind of go and anticipate. We've already determined our Lasix dose. Our patient has severe edema. We know when a patient has a lot of edema and a lot of congestion, he might be 10, 15 liters above his dry weight. So we will anticipate that making him pee this extra 10 to 15 liters will create hypernatremia, metabolic alkalosis, hypokalemia, hypomagnesemia. And I think you are one of the advocates of achieving balanced diuretics and thinking ahead of time, avoiding running into these issues. So how are you deciding whether you want a second or third diuretic on top of this? Are you basing that on your first urine sodium response? What are your goals with your first Lasix dose? And what are your goals with your additional diuretics? And how are you preventing hypokalemia and hypomagnesemia, Frederik?
Um, we of course, and when I show you this figure, the macula densa, it is located at the end of the thick ascending limb of the loop of Henle. So which means you have had the proximal tubule before that. And so you should realize that the kidney is actually completely blind to sodium. The only thing that the kidney reacts on is chloride. And so by bringing more chloride from the proximal tubules to the macula densa, you will act like a brake on the neurohumoral system. Also, in the proximal tubules, they are very leaky. And because they are very leaky, what you absorb there, it is actually isotonic. So it doesn't have any impact on homeostasis. This is what you like. And these were the rationalities behind the trial that we did, which was called the ADVOR trial, published in the New England, with acetazolamide in acute heart failure. Yeah, you might skip this for a moment. And so basically what we saw was that when we used upfront acetazolamide, we had a number needed to treat between 8 and 9 of getting a patient more dry, perfectly dry within 3 days. And so this is because the acetazolamide will get you more balanced diuresis and will act as a brake on that neurohumoral system that really tries to offset the effect of your loop diuretics. So I use acetazolamide in almost everybody up front. I think only contraindications for this is a patient that is not intubated, who has respiratory compromise, and where you are like a little bit worried about the metabolic compensation for the respiratory acidosis. So this might be a situation where you need to be a little bit careful. The other situation is when you have hypernatremia. Now, hypernatremia, we can talk about this as well, but this is a iatrogenic problem because we don't get so much salt out, and we only get the water out of it. So this is an iatrogenic problem. But ADVOR, acetazolamide, increases also free water excretion. So when you are using acetazolamide, you can get a patient pee like 8-9 liters a day easily. So you should allow them to drink a little bit more, and that's no problem. If they pee out 8 liter, they can drink 3 liter. That's no problem. Also in ADVOR, we anticipated for the additional potassium and magnesium loss by giving everybody a maintenance infusion with dextrose, which is pure water, with 3 grams of magnesium sulfate and 40 to 50 megs of potassium. And this is, if you go back to the previous slides, it's all on balanced natriuresis. So you should really try not only to get the fluid out, but also to get the electrolytes right.
Yeah. So I think this could head us to the urine sodium part of the discussion. Do you think it's a must? Should clinicians taking care of heart failure patients measure urine sodium obligatory in every patient they're decongesting, or is it good enough to just look at urine output and kind of wing it from there?
So there is actually a pretty good correlation between urine sodium and urine output. So I would say in the easy heart failure patient, I'm not talking about the complex cardiorenal right heart failure, repeated congestion. I think when you're looking at urine output, that works well. Like the most important thing is get patients on the right heart failure drugs, and they will do well. Get them diuresed. But in the complex cardiorenal patient, this is a different ballgame, because we know, and this is what you already said yourself, Eduardo, on the right-hand side, you see the study with tolvaptan. If you get only water out, you make no impact on clinical prognosis. And on the left-hand side, this is the ROSE trial. And this trial, they measured the electrolytes. And what you see is that even if you have a net negative fluid balance. If you have a positive sodium balance, you do a lot worse. So what actually is determining prognosis is getting the salt out of the patient. And so when we pee out, if you're doing urine sodium concentrations a lot, you will see that 100, it's about like the magic number of a very good response. If you're above 100, you have a patient that is diuresing pretty well. But 100, it's hypotonic. So this means that if a patient comes in with like 5 liter fluid overload, this means like 5 times 150 max sodium. So you probably want to get 750 max salt out of this patient, but you're going to pee only hypotonic. So you will actually need to get more than the 5 liters out of him. You will probably need to get 7.5 liters out of it, which means that you should provide free water, or you should allow your patient to drink to get actually the salt out of it.
Yeah, that's absolutely true. Actually, when we don't have a urine sodium that's close to 140, then we are already thinking that hypernatremia is coming. So, and sometimes we can get urine sodium to 140 when we combine diuretics. I've seen that happen a lot. So when I'm in the 140 milliequivalents per liter of urine sodium, I'm very happy. I'm not sure if you actually get that feeling of, oh, we are having a completely balanced natriuresis.
It's very high. We will not. I'm already like maybe cardiologists are a little bit more easily satisfied. If I'm above 100, I'm always happy. So, but the key thing is that people don't realize, because like the edema is 99% water. It's 99% water, but the edema will follow the electrolytes. So many patients which we have decongested and we think, oh, marvelous, there's no edema whatsoever, like, and they say, I feel thirsty, and what I would suggest is measure the osmolality, and you will see like the osmolality is like sky high. This patient is thirsty for a reason, and this is because you didn't get the salt out. So allow this patient to drink and maybe get back a little bit edema, because you will go on with decongesting this patient and eventually get the salt out. So see, to get the salt out, we need to provide more water to the patient, which is contradictory because in the beginning we had too much water. We lose way too much potassium. So be aggressive with your potassium supplements. I always keep the potassium above 4. This is a standing order. The nurses, they know that I'm very upset when I'm coming into the unit and I see a patient with a potassium of 3.7. And you will get a lot less muscle cramps and things like that if you proactively provide 3 grams of magnesium and you keep the potassium above 4. Then you don't have this kind of problems. And then the second important thing is when you're providing potassium, don't use I don't know whether it's called like that as well, potassium gluconate, but use potassium chloride. Because the other thing that you will see is, and it's a little bit reverse of the story about fluids, balanced fluids versus non-balanced fluids. With diuretics, it's the same. You will actually lose the body will keep the chloride constant, and if you eat too much salt, like it will buffer the sodium, and you will lose the chloride. So you end up in a situation where you have too much sodium for chloride. So when you're diuresing a patient, especially when you're using continuous loop diuretic drips, you will see the chloride go down. And this means you will get a lot of neuronal activation. And that is where people will not respond anymore to your diuretics. And by providing a lot of potassium chloride, you will prevent this hypochloremia, which is a very potent reason for diuretic resistance.
Yeah, and I think that makes much more sense than just giving sodium chloride, which some people do that. I used to do it. I used to be a believer on hypertonic saline to replace the chloride that we're losing and kind of get a better diuretic response. But then when you think about it, what you're trying to achieve is a negative, not natriuresis, but that's not the goal. It's not natriuresis. The goal is a negative sodium balance. And this is going to be harder to achieve. if you're replacing the sodium losses. And so replacing chloride in the form of potassium, it's still getting you, helping you get rid of the sodium. And then, of course, now in the acetazolamide era, which I think that's thanks to you, we are no longer reaching out for 3% saline boluses because we have a much better way to kind of cut through this diuretic resistance caused by hypochloremia. Wouldn't you agree?
Agree. I think there's a slide on the chloride evolutions in Adver. It might be the next one, I think. Or one, no, it was the previous one. I'm sorry. So yeah, here
Yeah, that one.
you can see it. So this is actually the Adver trial. So in blue is loop diuretic monotherapy. In red is acetazolamide. So what you see, if your chloride is normal and you give acetazolamide, it stays exactly what it is because acetazolamide, it's a chloride preserving agent. You will lose more sodium and you will actually, just like you get balanced fluids in, you get balanced fluids out. And actually, when your chloride is low, you will actually regain it quicker when you add acetazolamide. So acetazolamide, it is your brake on the neuronal system. So what people sometimes misunderstand from Adver was not a trial on diuretic resistance. We didn't select patient with diuretic resistance. We gave it upfront to prevent diuretic resistance, which is like a difference with thiazides. Thiazides are your diuretic to break diuretic resistance. So if your patient becomes, after a couple of days, diuretic resistant because you have used so much proximal diuretics that distal nephron has become hypertrophied, this is where you want to have thiazides. And also in that case, like the typical vicious cycle of intensive care is that like you get too much crystalloids, your patient get fluid overloaded, they only know loop diuretics there and they give loop diuretics which give you hypotonic urine and the sodium stays in the patient and the fluid goes out. And at a certain moment in time, they get fluids again, and you get the situation of hypernatremia and hypervolemia, which is totally iatrogenic. So the solution there is then to block everything distal, because like the thiazides, the MRA, they get these are the ones which I give like spiral 400, chlorthalidone 100. So really block everything distal to get the concentration of sodium as high as possible. Like if you have hyponatremia, it's reversed. Like you try to stay away a little bit from that. You go more proximally. You can use then the urine electrolytes also to see. You basically want to have your urine sodium concentration there at a good level. I would say above 80, 85. But you want to have it to have your urine sodium plus potassium, you want to have it lower than your serum values to make sure that you don't worsen the hyponatremia. So this is the electrolyte-free water excretion that you calculate then.
I love it. I love it. So maybe I just want to take a moment and summarize a little bit about what we've discussed, and then just in our last 5 minutes here, we can touch on anything else. So you're using Lasix as your backbone. You're ordering it in intermittent boluses at a high dose, enough to actually get a good urine response, and you're going to decide, do I want to do this once daily, BID, TID, or 4 times a day? And that's going to depend on how much you need to get off your patient. Early on, you're going to try to start acetazolamide to prevent alkalosis, but also to prevent chloride loss and diuretic resistance. You're going to consider when the sodium's already high, maybe somebody is already diuresed a patient, but really just peed out water and not enough salt. So the sodium's climbing. You're going to consider blocking the distal nephron. And primarily how you're going to do that is through using things like thiazides, so metolazone or chlorthalidone, but also your MRAs like spironolactone that are going to act distally. Now, we know that low chloride is heavily implicated in diuretic resistance for all the reasons that we talked about. And your first approach to treating that is to give lots of potassium chloride. So if you keep the potassium high using potassium chloride, you have less hypochloremia and less hypochloremia-induced diuretic resistance. This means that you often won't have to use 3% saline, for example, to turn off the kind of renin-angiotensin-aldosterone system, because 3% does carry the drawback that you're giving them a big sodium load, and yet we're trying to get rid of sodium. Is that kind of a fair summary of where we're at there?
I
That's a
couldn't
fantastic.
have said it better myself. It was perfect, Ross. I think what people should realize is that hypertonic saline, it is actually hypertonic chloride that you're giving. And sometimes like you run in late in the case and the neurohormones are like through the roof and like it is very effective to get them down. And you will eventually add acetazolamide and do all things to get the sodium out. So I use it like maybe 2 or 3 times a year, but I really don't need it in any other cases. And you will see that people who really like it, it's very often the people who use continuous high dose drips of loop diuretics.
And I will just say though, and maybe this is not to counter that point, but certainly just to raise kind of the roundness of the discussion. If you look at the evidentiary basis for diuretics, hypertonic saline arguably has the best evidence that it improves patient-reported outcomes. There was a fantastic systematic review by Liu et al. In 2021 in Critical Care Medicine. I think it was a meta-analysis of about 10 patients with acute decompensated heart failure, and I believe diuretic resistance as well. And they demonstrated a fairly robust mortality benefit from using hypertonic saline in these patients. And so I guess I always just think of that I think, and certainly most of those studies were before acetazolamide use was widespread, because acetazolamide use being widespread has only come about in recent years, thanks to in part to your work. So I guess maybe if, as you say, if we are not using acetazolamide and if we're not as mindful about the role of chloride in diuretic resistance, hypertonic saline is certainly better than nothing, but perhaps we can prevent the need for hypertonic saline more generally by targeting a high potassium, using potassium chloride, and using chloride sparing diuretics, for example, acetazolamide. Is that a fair kind of appraisal of both sides of that argument there?
Just one caveat is that like most of the evidence with hypertonic saline, it comes from non-randomized observational studies. So I wouldn't dare to say that hypertonic saline has shown a mortality benefit in heart failure. I don't think that we can say this. This is observational data with a lot of possible confounding. I think what is key that there I have never seen a study with hypertonic saline actually showing very simple that you improve net negative natriuresis. So basically, most of the time, what you give in, it's what comes out on extra. So it's kind of a zero-sum game. I think that the most important benefit of the strategy is that you tune down the neurohormones, and all of those surrogate outcomes, they will improve. Like you will have less plasma renal activity, you will have better urine output, you will increase you will improve your creatinine. But I would argue that all of those are surrogate outcomes. So in the end, and certainly on the long run, I don't think, and I'm skeptical that this actually changes your prognosis.
That makes sense. Now we're getting to the last couple minutes here, and I see a handful of questions that have come up about acetazolamide, because this is new, this is important. Let's talk a little bit about the logistics. Advar, I believe, was IV acetazolamide. Is oral acetazolamide acceptable here? What dose are you starting with? Are you ordering it and reassessing it on a daily? Just give us the nuts and bolts practical of using acetazolamide, and I think we'll have to end the webinar there.
In most countries, they don't seem to have it IV. We're lucky in Belgium we have. The oral bioavailability is pretty good. So we use 500 as well orally if we need to as a backup. You can go in very congested patients with gut edema. You can go to 2 times 500 or even 2 times 1000. But I would say that yeah, the evidence is there with the IV dose. If you don't have the IV dose, I think that the oral dose is pretty similar. Just again, dose on the higher side if you're not sure about the bioavailability. I don't know, Eduardo, do you agree with this? Like you're as a nephrologist, you probably have
Yeah.
much more experience with higher
So,
dosing.
So we have IV acetazolamide in some hospitals here in Mexico, and then there are others where we only have oral. And then for oral, I'll usually go for 500 BID as my initial dose. We get good responses, but this is all empirical. Of course, I have not randomized them to either IV or oral. I don't think anybody's doing that, but I can tell you, I mean, physiologically, if you see a huge bump in urine sodium after giving the drug when you were before only giving furosemide, that's good enough evidence for me that's working. That's what we wanted to achieve, right?
Absolutely. Awesome. Well, Frederick, thank you so much for having for coming on here. I think we might have to have you back because I think there's still some more discussion to have around this. Certainly, this is just scratching the surface. Even though for me it feels like a deep dive, I know that this is just scratching the surface of what you have. So thanks so much for joining us, and thanks for everyone for tuning in.
Great pleasure.
Nice seeing you guys. Always a pleasure.
All right, we'll talk soon.